It's showtime.
The broadcast is now starting. All attendees are in listen-only mode.
You may think that I'm talking foolish. You've heard that I'm wild and I'm free. You may wonder how I can promise you now this love that I feel for you always will be. But you're not just time that I'm killing. I'm no longer one of those guys. As sure as I live, this love that I give is gonna be yours until the day that I die. Oh baby, I'm gonna love you forever, forever and ever, amen. As long as old men sit and talk about the weather, as long as old women sit and talk about old men, if you wonder how long I'll be faithful, I'll be happy to tell you again. I'm gonna love you forever and ever, forever and ever, amen. They say time takes its toll on the body, makes the young girl's brown hair turn gray. Well, honey, I don't care, I ain't in love with your hair, and if it all fell out, well, I'd love you anyway. They say time can play tricks on memory, make people forget things they knew. Well, it's easy to see, it's happening to me. I've already forgotten every woman but you. Oh, darling, I'm gonna love you forever, forever and ever, amen. As long as old men sit and talk about the weather, as long as old women sit and talk about old men, if you wonder how long I'll be faithful, just listen to how this song ends. I'm gonna love you forever and ever, forever and ever, amen. I'm gonna love you forever and ever, forever and ever, forever and ever, forever and ever, amen.
Wow. That was Randy Travis, the best country music singer of all time. And today will be Randy Travis Day. He will entertain us with all the music. Good morning, everybody. This is Dr. John Minarsik. It's 9 o'clock in the morning in Chicago. And today is Thursday, April 19th. And this will be our 63rd 2-hour session in Global Medical School Pathology. Probably out of about, maybe 71 or 72 sessions by the time we're done with this, so you know we're in the home stretch. I think if somebody asked me to list my 100 favorite country and western songs of all time, I think about 90 of them would be by Randy Travis, so I had to decide whether to do Country and Western Day or Randy Travis Day, so we'll hear everything from Randy today. I guess it's about time we do our test. Make sure you could hear the music and hear me and see the little animal. Can you hear me? Looks like you can. Second question is, what do you see on your screen? Yeah, it's a, actually this is a jaguar. This is a baby jaguar. My grandbabies call me Grandpa Jaguar because when they were little tiny kids, I convinced them I was a real jaguar. And then when they got older, they knew I was full of baloney, but they didn't want to hurt my feelings, so they still call me Grandpa Jaguar. One announcement before we start today, and then we'll start. The announcement is, I have decided, because I have to schedule a very, very important speaker here, that the very last class will be on May 31st. That's a Thursday. Okay, we will not go into June at all. We will be completely done with this course by the end of May. It's kind of interesting because May is one of those weird months that actually has 10 Tuesdays and Thursdays. And psychologically, I don't think it's right to go into the so-called summer month of June because by then you are definitely out of school, if not in reality, at least in your mind. So May 31st will be our graduation day. We will not do much teaching on that day. We'll just have wild celebrations. I want you all to come. I want you all to be here. You all get special presents and honors as well. And we will have the most widely respected pathologist in the entire world, Dr. Vinay Kumar, speak to you. You all know who Robbins is. He's the guy that, wrote your book, and I imagine every one of you knows about Robbins. And if you look at who wrote the book, it's actually Dr. Vinay Kumar. He wrote many chapters, and he's the editor. And of course, the original Dr. Robbins has been in pathologist heaven for a long time. But Dr. Kumar is carrying on the tradition, and he'll have something very important to tell you. And believe me, I'll make it worth your while, because everybody will get some type of recognition. So tell all your friends about it. I'm going to do every trick I can, every threat, every carrot to get you there. And remember, for those of you that actually have done the Rock Lab cases, not only will you get the honors, but you will get a big, big, big honor of being able to get good references from me, for what it's worth. A lot of people don't think my references are worth anything, but I think they are. Okay, let's start the class. Once again, the chapter on female reproductive system is long, but like the chapter on male, it's very graphic, and I think it's very, very logical as well. So I don't know why they call it female reproductive system, where in the male they just called it the male genital tract. Maybe it's a PC thing. Maybe women have to get a little more special wording than just female genital tract like the males did. So where we ended off is at the cervix. And if you remember, we talked about the different topics we're going to talk about in the cervix. And remember, we're traveling up from the vulva to the vagina to the cervix to the corpus of the uterus to the fallopian tubes to the ovaries, and even say a few words about diseases of placenta and pregnancy. And remember, we defined the squamo-columnar junction, both grossly as well as microscopically. We showed you a few normal cells, what to expect when you exfoliate those cells. And here's where we left off. We left off on the concept of squamous metaplasia. We've hit on squamous metaplasia, at least a dozen times during this course. And this is no difference from the squamous metaplasia you might see at any other squamo-columnar junction in your body, like the anus or like the lower esophagus. It's the same process. And I want to go into it in a little more detail now because it's the cervix in which we usually talk about squamous metaplasia. The concept being, if this is the line between columnar and squamous, injuries to the columnar result in a process of protection by making more cells called squamous metaplasia. That's true everywhere in the body, even though we've seen cases where it could be the opposite, where it's columnar replacing squamous, like in the lower esophagus. The general process of squamous metaplasia is normal squamous cells replacing normal columnar cells. So if you were to look at a columnar mucosa like you see here, and remember this is up from the squamo-columnar junction, you're now in the endocervix technically, and you see some nice looking columnar cells. Remember, there are always a few little cells underneath there which are less obvious. Maybe you could start to see a few of them here as so-called reserve cells. This is what they're called in cytology too. So even though the prominent ones are the columnar cells, there are a few reserve cells giving rise to those more differentiated columnar cells. Well, what happens in the process of metaplasia is that the reserve cells give rise to more than one layer of cells. And at first they may look like they're a little columnar, but eventually as that process continues from the transformation zone into the zone of squamous, these layers become more flattened out. So whereas on the left here, in the so-called pure columnar zone, we had columnar cells and reserve cells, whereas right to the right of where the squamo-columnar junction used to be, we now have 100% squamous cells, like you see here. And of course, they have their basal cells too. So no matter, even though you concentrate on the non-basal cells, there always has to be a basal cell there giving rise to the more differentiated cells. And here are the two zones in between. Here's pure columnar. Here's pure squamous. Here are some reserve cells pushing up several layers of what still may look like columnar cells, and now it's starting to look more and more squamous. And there you go. So that's the process, and I think that was very much worth showing because we've talked about metaplasia many times, and this is exactly what happens both conceptually as well in real life down here. Once again, here is a nice little pap smear in which you see a lot of superficial cells that have abundant cytoplasm, usually a tiny nucleus. And once again, even if this is normal, it may be surrounded or in the middle of a bunch of acute inflammatory cells. So you can all recognize these as neutrophils without any problems, I'm pretty sure. Let's talk about a tumor, or let's just call it a mass, a polypoid mass protruding from the cervical os. Okay, now you know this white stuff is almost certainly squamous. I don't think you can really see the squamo-columnar junction very well, but you see something protruding out of it. And everything still looks pretty smooth, so as sort of a test question, I would probably say, what is this most likely? Cancer, breech presentation, HPV, could it be a polyp? And of course, I think you probably instinctively know that when you see a nice well-defined cervical os and there is something also that's very smooth protruding out of it, it's going to be a clean, non-truly neoplastic polyp. Now, can I ask you one question? I just popped out the window here. Most of you got the right answer. Do you think that the surface of this polyp is more likely covered with columnar or squamous epithelium? I got a mixed opinion here, and actually it really could be either one, but if it's coming from the endocervix, what is most likely the predominant mucosa on here? Of course, columnar is the answer, but remember, being an area now which is much more subject to trauma and inflammation and instrumentation and the cruel world in general, there's no doubt this may be having some squamous metaplasia on the surface as well. Here is a section of that polyp, and if I told you that it is a predominantly connective tissue structure, but there's still some rather normal appearing glands here, you would probably confirm it as an endocervical polyp because it's predominantly composed of endocervical cells. I guess you could have an ectocervical polyp technically that's squamous in all areas, but most of the polyps that you see, probably the most benign form of a growth that could come out of the cervix, are arising in the endocervix. Here is the general plan now, like we went from columnar to squamous, let's look at the sequence of changes that go from a normal squamous mucosa to a carcinoma in situ. And we've seen this elsewhere as well. We kind of showed something like this in the ENT presentation as well. But this is absolutely normal squamous. You can see there's sort of a basaloid group of cells at the bottom, and then they're sort of columnar or cuboidal. But as they rise up, they become more flat. And this is, of course, non-keratinized, so you're not going to see any cells at the top that don't have nuclei. The spectrum of changes going from completely normal to cancer in situ is generally now termed CIN, for cervical intraepithelial neoplasia. The technical word, which is still used very often, and has been dysplasia. So in the old days, if you thought that these changes here were not as severe as the other ones, but they don't really look quite normal. There's atypical cells, there's big cells. It doesn't mature as nicely as you see here. If you want to call this mild dysplasia, you're absolutely correct. It's also called CIN1. If you think that the one here in the middle is a little bit worse than this, but it's not exactly totally unorganized tissue, there's still some attempt at a maturation going from columnar to flat, you might want to call this CIN2. Pathologists may very well call it moderate dysplasia as well. But when you see that the cells at the basal part of the epithelium, near the basement membrane, look almost identical to the cells at the surface. There's no attempt at maturation. In addition, there's at least one, maybe two or three mitoses here. There's probably an abnormal mitosis. Then you could probably call this severe. Now, the nice thing about the CIN classification is that severe dysplasia, or CIN3, is also, for all practical purposes, carcinoma in situ. So you no longer have to struggle and fear the malpractice attorneys, whether you're going to call something severe dysplasia, and he's going to send it out to a guy at Harvard that's going to call it carcinoma in situ, so you'll be accused of missing cancer, because now they're in the same category. So high-grade dysplasia, or if you want to put the Roman numeral 3 for CIN3, is equivalent to carcinoma in situ. Now, the feeling is that carcinoma in situ will eventually infiltrate. There's also a feeling that the lesser forms of dysplasia, like CIN1, maybe CIN2, may not. They may revert back to normal. This has been demonstrated in the literature many times. But I think once you say severe dysplasia, CIN3, you can't afford to bet on the patient's life that this is not going to infiltrate. You have to take it out. You have to at least do a local cone. You have to watch it very carefully. Another term that has been used now in the last generation or so, especially for cytology, if we haven't had enough terminologies for this process, it seems like every generation some jackass decides to introduce another nomenclature so they look like they're doing something new. It's also called SIL, for squamous intraepithelial lesions. So as you might guess, this would be called low-grade SIL. This would be called high-grade SIL if you were looking at it predominantly from a cytologic point of view. This is a very important concept in general. It applies to all the other squamo-columnar junctions, and by the way, that's why it's yellow. Okay, now the question also comes up very often is, we know that carcinoma, squamous cell carcinoma of the cervix, is caused by HPV. And then, of course, we also know that condylomas are caused by HPV. So the question is, can you really differentiate forms of condylomatous hyperplasia or coilocytosis from various forms of dysplasia? And the answer is no. Okay, now whereas the squamous epithelium here on the right has a lot of these little spaces surrounding the nucleus, which we call coilocytosis, especially the cytologists love to call it coilocytosis. Whereas on the left here, we have a lot of atypia. It's also abnormal. It's one of the CINs. I'd probably call it about a 2 in my opinion. I wouldn't call it a 3. So the question is, which one is worse? They're both atypical. Well, I think that the one that loses the classical coilocytosis and goes more into dysplasia is probably going to progress ultimately. Condylomas, may eventually have malignant changes or change to go into severe dysplasia and infiltration, but this is the one you would worry about more. Now, are they both potentially caused by exactly the same thing? I would say yes. In fact, it's more than potentially, it's for sure. Now, here's another thing I want to show you. Here's a cervix from the point of view of the OB doc who's looking at a raw squamocolumnar junction. It's hemorrhagic. It's not as nicely defined as we see. So you would not be too surprised if when you took sections through this, you would see something like this on the top that looks like it's just about no difference from the bottom as it is from the middle or the top. And in addition, you could probably see a couple nuclei, maybe an abnormal one. So I don't think anybody would have any trouble calling this severe dysplasia, high-grade SIL, a CIN3, except all three of those terms would be wrong. And the reason why it's wrong is because we got a tiny little area here that has broken through this basement membrane. This is now a potentially metastasizable lesion. That's why when the docs do a nice cone biopsy or cold cone or LEAP or whatever they do now for these things, we make very, very, very sure that we look at this, try to get this entire basement membrane here and see if there's any breaching of it, because that makes a big, big, big difference in the terms of the patient's prognosis. Okay, quiz time. What we got here are normal squamous cells from a pap smear in the northwest, and you can see in this area the nuclei are small, the cytoplasm is abundant. Sometimes they stain green, sometimes they stain orange. Why they stain differently, I don't know. I'm sure somebody does, but this is so classical. Oh, there's probably even a few inflammatory cells normally. So I want to tell you that these three images here, one of them is CIN1 or mild dysplasia, one of them is CIN2 or moderate dysplasia, and one of them, for all practical purposes, might as well be called cancer cells because they are, because it's CIN3. The problem is when you look at cytology, you don't know whether they've infiltrated or not because you're just scraping the cells off the surface. So here's the first question. What is this? CIN1, 2, or 3 in the northeast? Okay, what is this? CIN1, 2, or 3 in the southeast? Good. What would you call this one in the southwest? CIN1, 2, or 3? Yeah, you all got it right. And even though there's a lot of very specific criteria in terms of nuclear size or what they call the NC ratio, for example, up here, there is a very low NC ratio because the nucleus is about only 1/5 or 1/10 of the diameter of the cell. But these nuclei here are more than a half, so that's a high NC ratio. And of course, they talk about how big are the cells, pleomorphism, how dark are the cells, hyperchromasia, and of course, if you were to find that one of these cells is in mitosis, maybe going in 3 different directions, you have a very, very, very confident feeling by calling it cancer. The thing is, you don't know if it's infiltrated or not. Okay. I think we're done with our discussion of cervical carcinoma in general. It's a disease that used to be one of the biggest killers of women, perhaps second only to breast, and now is, for all practical purposes, gone. And that's because this guy came around named Dr. Papanicolaou, and he said, let's screen these women regularly and smear the slides on the cells on a slide. And if we see some of these atypical changes, let's biopsy it, or let's do a hysterectomy or whatever. So in all practical purposes, we've cured cervical carcinoma. So I think that this is one of the things in which pap smears, have generally saved probably millions of lives. Of course, now there are more specific tests for the actual HPV virus, and that may help also as an adjunct screening test. And of course, right now the big debate that's going on is, with all of our knowledge about HPV and ways to detect it, do we really have to do all these pap smears all the time, or can we more categorize them? And that's a very controversial thing, especially when money is involved, so I'm not going to deal with it. Okay, let's move up now to the endometrium. Okay, the endometrium has a functional histology, in other words, a regular change in the appearance of the endometrial glandular cells on a monthly basis in premenopausal women. We're going to show you what those normal changes are. We're going to talk about the reasons why women may bleed for other than normal monthly menstrual reasons, and that's called dysfunctional uterine bleeding. We're going to show some inflammation, talk about the common things that cause them, and of course I think you already know what the appearance is going to look like. We're going to talk about adenomyosis and endometriosis, which is really the same process, only adenomyosis is endometrial glands within the muscle, and endometriosis is normal endometrial glands outside the muscle into the surrounding tissues. Just as though we had a nice looking polyp of the endocervix, you can get polyps of the endometrium. They are often linked to the concept of hyperplasia, because an endometrium with multiple polyps may appear hyperplastic and may be hyperplastic under the same estrogenic changes that make the endometrial glandular cells divide in general. And of course, we're going to talk about the tumors, and because the endometrium is epithelial and glandular, all of the carcinomas, all of the malignancies of the endometrium are adenocarcinomas. Of course, 99% of the weight of the uterus is smooth muscle, so you can have stromal malignancies and benign tumors as well. And we'll generally talk about the difference between leiomyomas and leiomyosarcomas. This is a classical article written many years ago by Noyes, N-O-Y-E-S, and it still applies today. And you could read it if you want, but this is your cycle. This is your first 4 days. This is the menstrual cycle. Here are the rest of the days leading up to ovulation, which is regarded as 0. And during that time, primarily under the influence of estrogen, the so-called estrogenic pre-ovulatory phase, you have cell divisions in both the glands and the stroma. You have mitoses there. After ovulation, primarily under the influence of progesterone, or the progesterone phase, or the post-ovulatory phase, the kinds of things you see are, first of all, vacuoles at the base of the cell, which generally move towards the apex of the cells. They secrete. You then see the secretion within the lumen of the gland. And then towards the end of the secretory phase, you start to see decidual reactions, where you have decidual-looking cells, implying even a greater progesterone effect. And finally, here we are again, back to menstruation. So this is the cycle. So remember, pre-ovulation is called proliferative, primarily under the influence of estrogen. Secretory phase, also post-ovulatory phase, primarily under the influence of progesterone. And I don't want to make it sound like it's one or the other. Both hormones act at both phases, but I'm talking about the predominant action. So in practical purposes, the pathologist will report a D&C in a normal woman, because they normally don't do them during menses, as either proliferative or secretory. The proliferative or pre-ovulatory or estrogenic phase is characterized by mitotic figures in the glands and in the stroma surrounding the glands, okay, primarily under the influence of estrogen. in the post-ovulatory or secretory phase, it's primarily characterized by vacuoles within the cells, like you see here, as well as secretion within the lumen of the cells themselves. You don't see much secretion here, but the secretion in the lumen appears after the vacuoles. And then when you start to see the stroma looking like decidua, fatter, plumper cells, more edema, and then finally, when it gets to the point where you are having infiltrates of neutrophils, and hemorrhage, you are then within your menstrual phase. So, we're going to see in the lab, when we look at normal endometriums, that glands that have mitoses and stroma that has mitoses are most likely proliferative, and glands that have vacuoles and secretions are most likely secretory. Now, that's the normal physiology. Why? And it leads up to bleeding for about 4 days. So the question is, why would a woman bleed not in sync with this normal physiologic process? And that's one of the big reasons why OB docs see women, because of dysfunctional uterine bleeding. Well, the general concepts which are involved in bleeding other than normal physiologic times is that there may have been an anovulatory cycle in which the woman never ovulated. That would result in the bleeding being screwed up and the progesterone perhaps not knowing exactly when to kick in. Another thing is called an inadequate luteal phase. So in the development of the luteal phase, which is also primarily progesterone, there's not enough. Okay? Oral contraceptives screw up the cycle massively, as you would guess, because you're administering estrogen, progesterone type compounds externally, resulting in feedback to normal physiologic mechanisms. That's another very, very, very common cause. And of course, at menopause time, menopause does not start by just the woman completely stopping with her periods. She may skip a few times, she may have a heavy one, so usually around menopause time you have dysfunctional uterine bleeding, even normally. And of course, you're not supposed to bleed at all after menopause. So when a woman that is clearly postmenopausal, elderly woman, let's say, presents with uterine bleeding, can you please tell me what the number one concern is to her GYN doctor? Of course, cancer. Statistically, most postmenopausal DNCs are not cancer, but that, of course, is the primary concern. What would cause an inflammation of the endometrium? Well, if you remember, pelvic inflammatory disease, which we have not really gone into too much yet, or inflammation of the primarily the fallopian tube by either GC or chlamydia. Remember that mucosa of the tube connects directly to the mucosa of the uterus. It's all the same Mullerian type epithelium. It's a little bit different in terms of appearance. So probably the most common cause of endometritis is a PID, or a inflammation of the tube. Another very, very common and often severe cause is postpartum sepsis. In the process of that placenta being removed, there may be some parts of the placenta that are retained, what they call retained products of conception, or other situations in which the endometrium is now open to infection from organisms that normally would not be there. Birth control pills, again, of course, have been associated with endometritis by virtue of the fact that they're messing up the cycle, and the bleeding is not occurring at the right time normally. Believe it or not, tuberculosis, granulomatous inflammation in the endometrium, is usually tuberculosis. So worldwide, probably TB is a very big cause of endometritis, not so much in the United States. And of course, it should probably also be reminded, although it's logical, that introducing a foreign body within the uterus, rubbing against that endometrium like an intrauterine device, has often been indicted as a cause of endometritis as well. Somebody said, what is BCPs? Birth control pills. Okay, let's talk about the concept of adenomyosis / endometriosis now. Now, we all know that endometrial glands, normal endometrial glands, should be confined to the mucosa of the uterus. It's a nice layer. You could see it very nicely. We'll see a picture. It's usually about a millimeter thick in the proliferative phase, maybe a couple millimeters thick in the secretory phase. It gets a little thicker and juicier after ovulation. But sometimes these glands just don't stay there. Sometimes they go into the muscle and they're still perfectly normal glands and they still respond to their cyclical changes, but they are just within the muscle. This adenomyosis is also called endometriosis interna because it stays internally within the uterus. Sometimes these normal glands, they're not cancerous, they're normal. They're seen outside of the uterus, perhaps in the broad ligament or the ovary or the umbilicus or the bowel. Very, very rarely would you see them above the diaphragm, but that's been reported as well in rare cases. So, endometriosis interna is never called that anymore. It's just called adenomyosis, or normal endometrial glands in the myometrium. Sometimes it could cause a thickening of the muscle where it actually looks like a leiomyoma. And endometriosis externa is normal endometrial glands like you see here, outside of the uterus completely. So once again, here is a uterus. I'm not too sure where the endometrium is, but you can see it's really thickened. And can I ask you, obviously, what are these little hemorrhagic areas that are making this myometrium look a little fatter and thicker than usual? You know that these are normal glands. They're hemorrhage. And once again, you could even, in a premenopausal woman, they may look like the normal proliferative pattern, the normal secretory pattern. Up here there's some bleeding. This could maybe have been the menstrual phase, but most likely, even if it's not, they usually look as like little hemorrhagic pinpoint foci within the muscle. Okay, now we talked about endometrial glands being in the muscle. What if these same glands decided to go way out beyond the uterus? That's called endometriosis, or endometriosis externa. But nobody calls it endometriosis externa. They just call it endometriosis. Now, since the beginning of time, even before I was interested in pathology, there were always two theories to explain this. One of them was the reverse menstruation theory, is that these glands are actually being deposited through the tubes into the abdominal cavity. The other theory is the embryologic rest theory, is that these endometrial glands were there from the beginning in the development of the endometrium, and they didn't come out. And believe it or not, as of today, I checked recently, nobody's really decided that yet, but it's one thing that everybody knows is that in a premenopausal woman, it could be probably one of the most common causes of abdominal and pelvic pain, especially if that pain is cyclical. So a woman comes in with pelvic or abdominal pain and she's very carefully interviewed with a history, and it turns out that these pains seem to occur in sync with some phase of her cycle, then it's a very, very high index of suspicion for endometriosis. Where do these little glands deposit? Well, like I said, anywhere in the abdominal cavity, but statistically, broad ligaments, number one area, in and around the ovary. Now, when they are in the ovary, they may cause the ovary to be very, very hemorrhagic, where this blood looks like chocolate. So chocolate cysts technically are linked with endometriosis, but don't forget, chocolate only refers to the consistency of the blood. So any bloody cyst due to any reason in which the blood has a thick chocolatey appearance, whether it's in the ovary or anywhere, could be called a chocolate cyst. Anywhere else studied along the peritoneum, visceral or parietal, in the bowel, small bowel, large bowel, anything that's intraperitoneal, and even the umbilicus. So these are the common places. Here is a uterus that you can see here on the top. Here's part of the tube. Here's the broad ligament. So this now is posterior to the uterus. That's probably part of an ovary here. And you can see what is posterior to the uterus. Well, it's the rectum. So OB doc does a laparoscopy and he sees these little hemorrhagic bloody excrescences on the serosa of the rectum. You know what he's going to think as a knee-jerk reflex. But it should be the same thing that you think. It's going to be probably little patches of endometriosis. Okay, here's a chocolate cyst. Grossly, looks like chocolate, very thick. This one happens to be inside of the ovary. And of course, a lot of this pigments may be picked up by macrophages, and you see these dark pigmented laden macrophages. You know if you stain them with the Prussian blue, they're going to be as green as all hell. And this is your classical chocolate cyst. I like that word, and a lot of people think that chocolate cyst means endometriosis, but actually chocolate cyst means the blood in the cyst looks like chocolate, period. Here's another uterus that's been opened longitudinally. Here is the cervix. I'm sorry, here's the internal os. Here's the external os and the squamo-columnar junction. You can see I'm going to run my pointer down what I think is approximately the squamo-columnar junction. So here's the endocervical canal between here and here. Here's the internal os. Here is some hemorrhage within the endometrial cavity. Here's a rather uniform muscle of myometrium. As you know, myometrium is probably 98% of the weight of the uterus, but 98% of the trouble is in the endometrium. There's a little nodule, looks extremely well defined, and whenever it looks extremely well defined, it's not doing any damage or infiltration. You can suspect that's a polyp, okay? And that's what the polyp might look like from not only somebody who's doing a colposcopy, but they're actually looking within the uterus itself. And of course, this woman might have had the procedure because of bleeding, because polyps can bleed. The things that they don't do is turn into cancer. Here are some glands in a polyp. You can see they're normal glands. Now, technically, they could change and have cyclical changes, you know, because there's a lot of vacuoles in these cells. I'm thinking maybe they're secretory. However, most of the endometrial polyps occur in postmenopausal women, in which you would not expect to see cyclical changes in the endometrial glands. Here's another uterus, cut the same way. I'm running my pointer along the squamo-columnar junction, and I think you're probably familiar with this now. Here's the external os, here's the internal os, here's the myometrium. And it looks like, if I told you that the endometrial lining is normally about 1 millimeter thick in the proliferative pre-ovulatory phase, and maybe a couple of millimeters thick in the secretory or post-ovulatory phase, it should normally be uniform. But look how thick and boggy it is. So, how many people want to call this multiple polyps, and how many people want to call this hyperplasia? I want to know right now. Give me your vote. Because, in all honesty, probably half the pathologists I know would call it multiple polyps, but probably the other half would call it hyperplasia. Because remember, hyperplasia does not have to be uniform. And the fact is, no matter what this is, you know that because of this increased tissue now, it's probably has an increased estrogenic effect. I think most people probably want to call this hyperplasia because it implies that there's an increased estrogenic effect. And of course, the estrogen effect, the hyperplasia, is not cancer, but remember, in the concept of initiator and promoter, this is promotion, this is hyperplasia. Is cancer more likely, is a carcinogen more likely to work in hyperplastic endometrium or non-hyperplastic endometrium? Okay, let's move on to another Very, very common thing. I'm not going to spend much time on them. And I want to show you something here. Here, take a look at this little lining here. Do you see right up here where the arrow is? It's very, very uniform, and it looks like it's only 1 or 2 millimeters thick. You know, here's your ruler down here for 3 centimeters. And this is normal endometrial surface. Look, you can see it over here too. But there seems to be something that protrudes out of that surface, and it's very, very, very well defined. And if you cut through it, it doesn't have that juicy glandular appearance. It looks exactly like the cut surface of the muscle, and microscopically it looks exactly like smooth muscle too. That's a leiomyoma. And once again, you know, 99% of all the leiomyomas are benign. They can occur submucosally, like it appears this one does, or within the myometrium completely, or subserosally as well. So they've always been classified into those 3 areas. By the way, look at this nice squamocolumnar junction here. And I'm going to show you a section through this leiomyoma now. Okay? And how many people here think that this looks exactly like normal smooth muscle? Like maybe this was from the myometrium rather than a leiomyoma. I think most people would say yes. And probably most pathologists might say yes. But let me tell you something. Maybe you might want to call that a mitotic figure there. I don't know. If you look real hard, maybe there's 1 or 2 things here. So, please listen. This is very, very important. And it's the reason why I'm a widow today. Okay? The number of mitotic figures in smooth muscle is the main determiner of whether it's a benign leiomyoma or a malignant leiomyosarcoma. And the rule generally was this. Let's say this is a high power field under your regular old microscope. And a high power field is usually somewhere in the range of about 500 power, like maybe 50 power on your objective and 10 on your ocular. So let's say that you looked at 10 of these high power fields and you saw maybe only 1 or 2 mitoses. You could say this is benign. But let's say you saw 3 or 4 or 5 or 6 or maybe almost 1 mitoses per high power field. Then it's almost certainly a sarcoma. And like any other sarcoma, it metastasizes usually early and usually through the blood. So the patient's first presenting symptom, like in the case of my wife, with a malignant smooth muscle tumor, is that they have pulmonary problems, like a cough or a cold that just doesn't heal. Okay, let's go back down to the most important part of the uterus to watch for cancer, and that's the endometrium. Because cancer of the uterus is almost entirely synonymous with adenocarcinoma of the endometrium, because that's where they occur, and statistically it's really, really high on the list of, well, women cancer killers. You could see that the endometrium here is not uniform, and in addition, it's very thick, irregular, boggy, hemorrhagic, and you're probably even wondering microscopically whether it might be invading some of those smooth muscle cells. That's a classical appearance grossly. If you look microscopically and you've determined that this muscle is really muscle out here rather than the normal junction between endometrium and myometrium, then you could say it's invasive as well. And here, I think you would probably know what adjective to put in front of this adenocarcinoma. It begins with the P. This is a papillary adenocarcinoma. Though they can have all kinds of appearances, just like, it seems like everything that we've talked about so far that was adenocarcinoma, you could have almost any type of adjectival appearance on it. Of course, I don't know what this immunostain is here for, because if you see something like this in the uterus and the endometrium, you don't have to wonder whether it's coming from the uterus or not. This is not an appearance of a metastatic lesion. Okay. Here's another picture. And I think in this picture, let's say that this would normally be the thickness of a myometrium. It looks pretty uniform here. But look, do you see this white stuff going all the way towards the surface? And up here, it's really thinned it out. So, would you be astounded if you didn't find smooth muscle infiltration here microscopically? Of course you would be, because grossly it's infiltrated. Now, whether this is going to be papillary or not, I don't know. I have a feeling it might be, because it has kind of a shaggy appearance, but we'll never know because we didn't do a section of it. Here's a classical appearance. All of the standard criteria for malignancy are in these glands. Okay, first of all, it's irregular. Secondly, it's infiltrative. Thirdly, it's evoking an inflammatory response and even some necrosis over here. And also, you know, the glands are, of course, back to back in many areas. They're not separated by normal endometrial stroma. And secondly, there's a lot of hell of a pleomorphic looking bizarre cells here as well. Though this is like, I might as well ask the question as long as the window is open, but would most of you know that this was an adenocarcinoma of something like within a tenth of a second if you saw this on a step 1 exam? Thank you, thank you. Okay, so all of the adjectives that are generally given to adenocarcinomas, they could be papillary, they could be polypoid, which is like papillary but grossly. They can have clear cells. They can have perhaps a squamous looking component as well, but like in the GI tract, whenever you see squamous with adeno, the squamous component is most likely to be benign, metaplastic, but it could also be malignant as well. It could secrete a lot of mucin. It could be serous, in which the cells don't look washed out with mucin, but they just look like normal cytoplasm. And of course, once again, just as though we've seen everywhere else in the body, it would be preceded by technically EIN, or endometrial carcinoma in situ, which is the same as adenocarcinoma in situ, which could be called severely dysplastic glands, perhaps preceded by less dysplastic or even hyperplastic looking glands. Now, I'm not trying to oversimplify it. In a lot of cases, it's very hard to determine whether hyperplastic glands are dysplastic. Of course, the more you look at it, the more you'll probably think it is. And it's very, very difficult to look at a dysplastic gland and call it endometrial adenocarcinoma in situ, because that means you're predicting it's going to infiltrate. But if it is truly an adenocarcinoma, by the usual terminology, it will infiltrate, and of course eventually it will kill as well. They're related to increase of estrogen effect. Estrogen nourishes, smooth, multiplies the cells of the endometrium. So that would be a powerful promoter effect. It's also related to diethylstilbestrol. And if you wanted to do a profile, you know, like the police do profiles, if you want to do a profile of a woman that has adenocarcinoma endometrium, obesity is a big factor, diabetes is a big factor, hypertension is a big factor, and if she's never menstruated, she's been infertile, that's another factor as well. So if you were to go to an OB doc right now and say, what do you fear the most in your patients that are obese and diabetic and hypertensive and infertile, they'll instantly say adenocarcinoma of the endometrium. And remember, even though we're talking about endometrium, which is glandular, which would have an adenocarcinoma appearance, could there also be neoplasm of the underlying connective tissue as well? Or in other words, sarcomatous as well? Yes, and if that's the case, it's called adenosarcoma, or you have malignancy of both the epithelial or glandular as well as the underlying connective tissue or stroma as well. By the way, what time is it? Oh, okay, we still got we're going to make this, I think. Grading and staging. Okay, I guess the TNM could technically be applied, but in adenocarcinoma of the endometrium, of course the staging is much more important than the grading. So even something that is grade 1 or very well differentiated, if it was outside the true pelvis, it could be a disaster. So staging is much more important than grading, and the classical landmarks to look for in staging would be if it's limited strictly to the corpus or the cavity of the uterus, it's stage 1. If it grows beyond that, it usually extends inferiorly to the cervix. So stage 2 is when it's gone to the cervix. Now, it could go completely outside the uterus at all, but if it stays within the true pelvis, it's stage 3. Now, if it's outside of the pelvis, including metastatic, or involving the mucosa of the bladder or rectum, then you know it's stage 4. So you can have a stage 3 that involves the rectum and bladder, but if it involves the mucosa, it's stage 4. And I like the fact that nobody has come up with a fancy system here. It still can be called well, moderate, or poor from the grading point of view, whether it looks like a lot like normal endometrium, a little like endometrium, or perhaps it's so poorly differentiated it doesn't even look like glands anymore, like we've seen in many other places. Last topic we will have are the topic of fallopian tubes. We kind of neglected those. The two major concerns with fallopian tubes are inflammation and neoplasms. And if you want to call a cyst a neoplasm, it's probably not a good term for it. It might be a tumorous protuberance, but it's not truly neoplastic. So those are the two concepts we're going to deal with fallopian tubes. And of course, the number one disease that you may see 9 times out of 10 if a woman has a fallopian tube problem is a salpingitis. Salpingitis is inflammation of the fallopian tube. It is generally referred to as PID. And even though salpingitis itself does not have to extend into the abdomen itself retrogradely or to the endometrium antegradely, it often does. So a salpingitis, which is significant in causing a lot of perhaps spread and inflammatory changes, is called PID. In the U.S., gonococcus and chlamydia are overwhelmingly the number one causes. The thing I've noticed is that, 10, 20, 30 years ago, you would say GC was almost all of the causes. Now, for some reason, chlamydia has become almost as popular as gonococcus. These are your two big organisms. If the acute inflammatory reaction is enough to significantly cause abscesses or dilate the lumen of the tube, that's called pyosalpinx. And as you know, the fallopian tubes are a complete open door to the abdominal cavity. Theoretically, you can go from the vulva into the abdominal cavity directly from the vagina to the uterus to the tubes to the infundibulum or the fimbriated end of the tubes, directly into the abdominal cavity. So it's a great source of peritonitis. Not only can the tubes become fibrotic and cause improper transportation ducts to the ovum, and therefore tubal pregnancies by blockage, but it can also cause adhesions to the surrounding tissues as well. So if a tube is blocked secondary to pelvic inflammatory disease because of the fibrosis, it may lead to sterility and infertility. And worldwide, it's a very, very common cause of sterility and infertility. What about peritubal cysts? They're very, very, very common. For those of you who have dissected cadavers last year, and I hope most of you have, I bet you that in every single case where you found a uterus and ovaries, assuming the woman still had them, which about half of them do, you probably found some kind of cystic structure in either the tube, the broad ligament, or the ovary. It's almost impossible to have a normal female reproductive system specimen that doesn't have some kind of cyst. Now, some of these cysts, of course, you know, can be due to endometriosis. Some of the cysts along the tube are called hydatid cysts. And they look very much like a grape. I think that hydatid is the Greek word for grape. They're also called hydatid cysts of Morgani, and they're Mullerian rests. So in the development of the Mullerian duct, some of these Mullerian rest cells happen to occur outside of the wall of the tube. Sometimes these are called peritubal cysts. Sometimes they're called paratubal. And if you did a Google word search, I think you'd probably find that peritubal is more common than paratubal, but they're all the same thing. And also remember, because that broad ligament is technically connecting that tube closer to the ovary, you can also have cysts in the broad ligament, which are mesonephric rests as well. So not only can you have Mullerian rests, but you could have mesonephric rests, which probably be closer to the ovary than the tube, but they could be anywhere in that connective tissue. Tubal neoplasms, true neoplasms now, not just cysts. Just like the endometrium is glandular, the mucosa of the tube is also glandular. It's very, very similar embryologically. It's all Mullerian. So a neoplasm of that would be an adenocarcinoma. Now I know what you're thinking. You're probably thinking, why didn't he mention that you couldn't have a benign adenoma of the fallopian tube? And actually you kind of caught me a little bit embarrassed, because I've never heard of an adenoma of the fallopian tube. So that's why I didn't mention it. I guess it's possible, but let's just say any glandular neoplasm of the fallopian tube mucosa would be regarded as an adenocarcinoma until proven otherwise. And also technically, remember, the wall of the fallopian tube, which we'll see in lab, is normal smooth muscle. So could you have a leiomyoma of it? Yes, you can. Could you have a leiomyosarcoma of the muscle of the wall of the tube? Yes, you can. The fact is, I don't think I've ever seen one. Okay, guess what? We're done with the entire Mullerian system. We're going to take our 10-minute break. We're going to hear some more Randy Travis. We're going to come back into ovary, pregnancy, and placenta. And who knows, maybe we'll be able to finish the whole thing today. I really don't know. But once again, type in any questions you might have during the break. I'll let you see the baby jaguar again while you're listening to 3 great Randy Travis songs. See you in 10, folks.
Singers singing about how they can love deeper than the oceans, higher than the stars above. Well, I come from the country and I know I ain't seen it all, but I heard that ocean's salty and the stars they sometimes fall, and that would not do justice to the way I feel for you. So I had to sing a song about all the things I knew. My love is deeper than the holler, stronger than the river, higher than the pine trees growing tall upon the hill. My love is purer than the snowflakes that fall in late December, and honest as a robin on a springtime windowsill, and longer than the song of a whippoorwill. From the back roads to the Broadway shows with 1,000,000 miles between, there's at least 1,000,000 love songs that people love to sing, and everyone is different, and everyone's the same, and this is just another way of saying the same thing. My love is deeper than the holler, stronger than the river, higher than the pine trees growing tall upon the hill. My love is purer than the snowflakes that fall in late December, and honest as a robin on the springtime windowsill, and longer than the song of a whippoorwill. My love is deeper than the holler, stronger than the river, higher than the pine trees growing tall upon the hill. My love is purer than the snowflakes that fall in late December, and honest as a robin on the springtime windowsill, and longer than the song of a whippoorwill. A whippoorwill. I ain't lived forever, but I've lived enough. And I've learned to be gentle, and I've learned to be tough. I found only two things that last till the end. One is your heroes, the other's your friends. Your heroes will help you find good in yourself. Your friends won't forsake you for somebody else. They'll both stand beside you through thick and through thin. And that's how it goes with heroes and friends. I grew up with cowboys I watched on TV. My friends and I sometimes pretended to be. Years have gone by, but now and again my heart rides the range with my heroes and friends. Your heroes will help you find good in yourself. Your friends won't forsake you for somebody else. They'll both stand beside you through thick and through thin. And that's how it goes with heroes and friends. Your heroes will help you find good in yourself. Your friends won't forsake you for somebody else. They'll both stand beside you through thick and through thin. And that's how it goes with heroes and friends. That's how it goes with heroes and friends. Last night I dug your picture out from our old dresser drawer. I set it on the table and I talked to it till 4. I read some more love letters right up till the break of dawn. Yeah, I've been sitting alone, digging up bones. Then I went through the jewelry and I found our wedding rings. I put mine on my finger and I gave yours a fling. Across this lonely bedroom of our recent broken home. Yeah, tonight I'm sitting alone, digging up bones. I'm digging up bones, I'm digging up bones. Exhuming things that's better left alone. I'm resurrecting memories of love that's dead and gone. Yeah, tonight I'm sitting alone, digging up bones. And I went through the closet and I found some things in there, like that pretty negligee that I bought you to wear. And I recall how good you looked each time you had it on. Yet tonight I'm sitting alone, digging up bones. I'm digging up bones, I'm digging up bones. Exhuming things that's better left alone. I'm resurrecting memories of love that's dead and gone. Yeah, now I'm sitting alone, digging up bones. I'm resurrecting memories of love that's dead and gone. Yeah, tonight I'm sitting alone, digging up bones. I'm digging up bones. Exhuming things that's better left alone. I'm resurrecting memories of love that's dead and gone. Yeah, tonight I'm sitting alone, digging up bones. I'm digging up bones. Exhuming things that's better left alone. I'm resurrecting memories of love that's dead and gone. Yeah, tonight I'm sitting
Wow. Thank you very much, Randy Travis, for great music. You know, I'm just kind of curious. I like country music. Perhaps it's not my favorite type, but there's a lot of really great stuff. I also like hip-hop a lot, too. So usually you can't usually find a person that is crazy about both country and hip-hop. They seem to be two completely ends of the spectrum. But I really like Randy Travis. Can I ask a question? Because the window is open. Did you like this music? And not everybody likes country, but I can't imagine somebody not liking Randy Travis. Okay, thanks a lot. I'm seeing almost unanimous positive support for the greatest country star in my lifetime. One more thought I got during the break is that is a plea again for everybody that's here, and there's a good number. Make sure you're here on the last day of May, the 31st, Thursday. Bring your friends, remind everybody. I want to have a really, really good turnout for Dr. Kumar, and also it's going to really worth your while. Not only will you get something very, very good out of this if you come, but I won't have to use threats like, if you don't show up for the last day of class, I'm going to flunk your asses. Okay, now that we said that, we're going to have a lot of people here. Do everything you can. It's going to be, and remember, this might be the only opportunity in your lifetime to talk directly, bring your microphones, and with the greatest pathologist in the entire world in terms of medical education. In fact, probably in terms of everything. When I grow up, I want to be like Dr. Kumar, even though he's probably a hell of a lot younger than me. Let's finish our discussion now on female reproductive system. And we're completely done with all Mullerian structures from the vagina to the fimbriated ends of the tubes. So there's really only one really big thing left, and of course those are ovaries. We'll talk about pregnancy. We'll talk a little bit about placentas too. So this is going to be the second half. Maybe we could do it today. I don't know. Maybe not. We still have a good number of slides left. Classically, again, like every other part of the body, you have to think of the three biggies: degenerative, inflammatory, and neoplasm. And you know, there are reasons for having inflammatory conditions of the ovaries. And I don't know if degenerative would really be a good adjective either, because normally the entire ovary degenerates with age. But there is a heck of a lot by way of benign cystic lesions of the ovary, and a heck of a lot tumors, both benign and malignant. So we'll be dealing with those a lot. And of course we'll also be talking about common diseases of early pregnancy as well as late. And then we'll be talking about my favorite topic, diseases of the placenta, something I generally consider myself a worldwide expert on, only because I had to be a worldwide expert on it at my defense in federal courts. But I don't know if I'll tell you that story later or not. Here's a good place to start, like we always do, with embryology. And as you know, the yolk sac is the primary source of germ cells, both male and female. As it matures into 6 weeks or so, some of these yolk sac primordial germ cells start to migrate into the hindgut. And from the hindgut, you could see they generally mix in with the mesonephric area to form the genital ridge. That's probably true in men and women, or males and females. And it's this genital ridge, of course, that gives rise, you know, to the ovary. So when you see a mature ovary with all of the various stages of follicles, this is ultimately derived from that mesonephric area. The same area that develops into the kidney now develops into the ovary. Just a little thing here: the mesovarium, of course, is the source of the blood, arterial venous blood of the ovary. The follicles are generally situated along the cortex. The so-called medulla of the ovary is more connective tissue and blood vessels. And of course there's the proper ovarian ligament as well. And you may remember, and we're going to go over this, is that the general maturation of follicles is from primary follicles developing right underneath the tunica into secondary follicles, into antral or Graafian secondary follicles. Ovulation occurs when that ovum is released, at which time, like we saw in the endometrium, the progesterone kicks in, and now you have the development of the corpus luteum. At some point in time, these nice yellow cells, luteum means yellow, become white because it's all fibrous tissue, and now it's called a corpus albicans. And some people might even go a step further and say corpora fibrosa, when it's almost entirely all fibrous tissue. When we talked about the tube before and its relationship to the ovary, we forgot to mention that the very distal end of the fallopian tube, where we left off in the Mullerian discussion, is filled with these little fimbria, and that's called the infundibulum. The next third of the tube or so is pretty dilated. That's why it's called the ampulla. It's a dilated structure. Then the closer you get towards the uterus, it becomes narrow or isthmus. And then once, of course, it gets into the uterus and joins with the endometrium, you then have the intramural or intrauterine part, which of course is not surrounded by the smooth muscle of the tube anymore. It's surrounded by the smooth muscle of the uterus. And let's see, do we have any questions for this? We asked you, in which ligament does the ovarian artery lie? Does anybody remember that? Anybody want to take a stab at it? Might have been a while since you did this. Haha, you don't know. No, it's not the broad. It's not the meso. Oh, yeah, the round ligament. I'm pretty sure it's the round ligament. If you're sure it's the round ligament, aha, suspensory ligament. Guess what? You could probably call this the mesovarium with the suspensory ligament then. If there's another name for it, who cares? Okay, so here we are now in the ovary itself. Here is your cadaver point of view, or autopsy point of view, in which you have the rectum posterior to the uterus and the bladder anterior. So, you know, uterine things like endometriosis can either go posteriorly to the rectum or anteriorly to the bladder. Here's your fallopian tube. And do you notice how the fallopian tubes are always anterior to the ovaries as well? You know, sometimes when you see a uterine specimen, you want to turn it so that the ovary is facing you, but that's improper anatomically. The ovary is always posterior to the fallopian tube. Here's the broad ligament here, and most likely the squiggly tube will eventually end in a nice fimbriated or infundibular portion. Probably the more dilated portion here, where you see a large lumen microscopically, is your the ampulla, and then where it narrows out there, very thin, is your isthmus, and of course it continues on into the uterus. Beautiful picture of the ovary. This is probably not a human because there's just too many follicles, but we're going to trace the development of the follicles all the way from the primordial follicles into the mature Graafian follicles, and even post-ovulation into the corpus luteum as well. Here's another nice picture. I guess we could call all of these primordial germ cells. At first they get surrounded by a little bit of epithelium. At first it's sort of squamous, then it becomes kind of cuboidal or columnar, which are primary follicles. When the primary follicles are large enough to store this fluid here, very, very rich in estrogen, called liquor folliculi, it then becomes a secondary or Graafian follicle. They're also called antral follicles because this wide area here is the antrum. And at this point, it will ovulate, and this entire follicle then, these very, very strongly estrogen-rich granulosa and thecal cells, will then be under the influence of progesterone to form a nice corpus luteum, which of course we can't see here. So what are the terms? The germinal epithelium arise from mesothelium around the capsule of the ovary. You have your ovum or oocyte. It has surrounded by a tunica albuginea. You have your primordial follicles, which are lined by sort of a squamous epithelium. The primary are more columnar or cuboidal. Once they have an antrum, it's called a Graafian or secondary follicle. The granulosa cells and thecal cells, just peripheral to those, are very, very rich in estrogen. And then, of course, after ovulation, this area is a very, very powerful source of progesterone. And of course, if a pregnancy has occurred, this corpus luteum will be huge. It might even be half or a third the size of the entire normal ovary, but if it has not occurred, it remains relatively small still. The thing that is always sure, though, it stands out like a light because it's very, very, very brightly yellow. And we said that anything that's yellow in the body is yellow because of fat, because these progesterone-producing cells are just rich in cholesterol precursors, which of course give rise to the progesterone. The follicle can deteriorate and become atretic. The corpus luteum can then become a corpus albicans as it ages. And of course, everything else, primarily in the cortex of the ovary, will be called stroma. So here's your oocyte. And when it has kind of a squamous covering, it's called primordial. When it becomes more columnar or cuboidal, it's then called primary follicles. But look, it's only one layer, isn't it? And you don't see any antrum there. When you finally, this is still a primary follicle. You can see a bright zona pellucida around the ovum, separating it from the granulosa cells. These will eventually deteriorate to become atretic follicles, but these are still primary follicles. Once, of course, you get into an area where the granulosa cells are surrounding the ovum. There's a wide open area here for storage of estrogen-rich colloid called liquor folliculi. Very much the same process by which the thyroid has follicles that are rich in thyroglobulin and thyroid hormone. This is very, very rich in estrogen also. So this is the antrum. This is a secondary or Graafian follicle. And here it is even bigger, in which the predominant thing now is the liquor folliculi, ovum, granulosa cells. And remember, even though these are granulosa cells, the cells completely surrounding them are called thecal, Thecal cells, and they're still rich in estrogen as well. But the thecal cells kind of flatten out and become poor in estrogen and more like a fibrous protective area, and that's called theca externa. And it's not rich in estrogen. So if I was to ask you, are thecomas developed from the theca interna much more likely to secrete estrogen than thecomas of the theca externa? Of course the answer is yes. Here we go. Here's your antrum. B, your granulosa cells, very rich in estrogen. C, theca interna. D, theca interna. They still look kind of plump like the granulosa cells, don't they? But by the time you get E here, the theca externa, you get basically fibrous sort of appearance. So let's say there's two kinds of thecomas, the ones that produced estrogen and the ones that look more like fibroblastic tumors like fibromas. And of course the ones that look more like fibromas would be from the theca externa. They're also called fibrothecomas. And if there are thecomas that secrete estrogen or they're functional, they're more likely developed from the theca interna, which are fatter and plumpier and making more estrogen. Here's a beautiful, beautiful corpus luteum. I mean, it's really a kind of a joy to see when you dissect a ovary. You see this bright yellow thing. Can only be a corpus luteum. Luteum means yellow. Here's why it's yellow: because the cells are just plumped up with cholesterol. They almost look like the foamy cholesterol-laden macrophages, don't they? And the reason why they're yellow is because progesterone is a product of cholesterol, and this is mostly cholesterol compounds, which are, of course, are fat. Here is a corpus luteum, and it's pretty big. And when it gets this big, you know, a significant percentage of the size of the ovary, you think this is probably a corpus luteum of pregnancy rather than just the corpus luteum of a post-ovulatory situation in which you have your predominance of progesterone now. Can't neglect the corpus albicans. Alba means white. And of course, fibrous tissue looks white. And of course, microscopically, it looks light pink, which is also kind of a white. And that's why it's called corpus albicans. It's non-functional. And some people, if the more fibrous tissue that appears in here, the more aging, it may actually be called then a corpora fibrosa. But who cares? So let's talk a little bit about estrogen and progesterone now. You can't ignore it in the topic of ovarian pathology. You know, estrogen and progesterone predominantly controlled by pituitary, FSH, and LH. We're not going to go into precise details. The primary purpose is to nurture, develop, grow the breast lobules, as well as to nurture, grow, develop endometrial glands. From a pathologic point of view, estrogen is often spoken about as being cardioprotective, and the reason why women generally get heart attacks 10 years later than men do, simply because they still have a lot of estrogen hanging around, while men in their 40s and 50s never had that. And once they are menopausal and they lose their estrogens, they are generally in the same risk category as males then, but 10 years later. And of course, we know that estrogen is bone mass protective, so the treatment for osteoporosis often includes very heavily, you know, estrogen combination as well, maybe some progesterone as well. Progesterone also controlled by FSH and LH, a very delicate thing. I don't even know if I quite understand it fully. It causes the endometrial glands to become secretory with vacuoles and secretions and decidua, rather than proliferative. And of course, it's key in the development of the implantation of the blastocyst after fertilization. And also remember, it's also very, very important for lactation, and might be even as important as the lactating hormone itself. Thyroid hormone, believe it or not, almost every hormone in the body, not just prolactin, but thyroid hormone, progesterone, estrogen, these are all needed for proper lactation. People think it's just one hormone, but progesterone is probably just as important. So what are the diseases of the ovaries? Well, we have cysts, we have tumors. We're not going to say much about inflammation. It's very, not too many diseases of the ovary are primary inflammatory diseases for reasons I just don't understand. However, it's almost impossible, especially in an older woman, not to see some type of cyst. And remember, in the development of the cortical follicles, those are cystic by nature as well. So there's basically two types of primary cysts of the ovaries. One of them, and they're both developed from the so-called follicles. There's follicular cysts rather than luteal cyst in the post-ovulatory follicle. They're very, very common. It's probably the most common type of thing. Here's a cyst of the ovary. There's also blood in that. I think you knew that. Here's one that's kind of big. You can see the fallopian tube overlying it. And you can see here now a massive cyst. And if you look at a lot of these follicular cysts, you'll still see some follicular cells. But remember, some of the very, very large cysts of the ovary are not developed from follicular epithelium, but they're developed from the so-called germinal Mullerian epithelium. So even though this looks like a massive tumor here, and you may think that it's from the Guinness Book, the largest tumors in the world, the 100-pound tumors, are usually developed from Mullerian epithelium, and specifically the mucinous ones are much more likely to be massive, 100-pound cysts than the serous ones. But follicular cysts generally can become large as well. The proof of the pudding would be you see some follicular-looking type cells in here. Here's a corpus luteum, and even though it's normally cystic in appearance, the central portion can have extensive liquefaction and can actually truly categorize or deserve the term cyst. And of course, if you see a bright yellow cyst in the ovary and it's yellow, there's only one kind of cyst it could be. It would be a corpus luteum cyst. And of course, microscopically, here it is on H&E. You would know that all of these cells are very, very, very much plump and stuffed with cholesterol, which means why it's yellow, because it's fatty. Polycystic ovarian disease. Now remember, you could have more than one cyst in the ovary for any reason, but there is a very, very common syndrome. Actually, it has a 5% prevalence, believe it or not, called polycystic ovary disease. It's also synonymous with the older term Stein-Leventhal syndrome. So, in about 5% of all women, one of the most common causes of her inability to ovulate, or oligomenorrhea, very, very inadequate small menstruation, also profiled as generally obese women, women that may have a little extra facial hair, more than they'd like to admit to. This is all the setting for polycystic ovarian disease, or Stein-Leventhal syndrome. Let's take a look at Stein-Leventhal, and that'll be our next slide. And the ovaries themselves are not massively enlarged. They're only about twice normal size. And if you look at the so-called cysts, they're more towards the cortex of the cut surface of the ovary, where the cysts or where the follicular development usually is. So if you're thinking that most of these cysts are really dilated follicles, you're absolutely right. And these are all a classical appearance. So a ovary that's about twice normal in size, you cut it open and you see a lot of predominantly cortical cysts. It's probably Stein-Leventhal syndrome. The woman is likely to be anovulatory. She's also likely to be obese and perhaps even a little bit hirsute. I wish I could tell you exactly what causes it or give you a gene, but still, as of today, the jury is out exactly what causes this. A lot of theories, but we're not going to waste your time talking about all the theories. Might as well get into the big topic now of, true tumors, true neoplasms of the ovary. I would like to think that I decaffeinated this a little bit, but it's not quite as simple as the male classification, in which we said everything was either germ cell or stromal. We're talking about a different anatomic structure now. But we can say that the two big classifications of ovarian tumors are tumors that develop ultimately, and this is the majority of them, from Mullerian type epithelium, and the other big category after that are the ones that develop from true germ cells. Now, please don't make the mistake like I did in one of my movies on YouTube of confusing germ cell with germinal. Okay? Mullerian epithelium is often called germinal, but it's not germ cell, because germ cells are ovums, right? They're sperm, they're ovum. So these are the two big categories, overwhelmingly Mullerian. If you wanted to add a third category of the so-called sex cord, like granulosa cells and thecal cells, you could add that to the list too. And remember, we said that in the testicle, nothing metastasizes to the testicle. Well, in the ovary, it occasionally is the site of metastases. For some reason, if you see a metastatic adenocarcinoma to the ovary, you might apply the crazy term Krukenberg tumor to it. And a Krukenberg tumor is technically a tumor of the stomach that is metastasized to the ovary, although anything can metastasize to the ovary. Why the ovary has a predilection for gastric metastases, I don't know, but technically anything can metastasize to the ovary. So, when you look at your Mullerian epithelium here, you could say either the glandular cells look serous, or the glandular cells look mucinous. Now this, of course, would produce a lot of mucin. This would, of course, would produce a lot of clear, watery fluid. Or you could say that the glandular cells look a lot like endometrial glands. Or you could say that not only are the glands malignant, but the connective tissue, the stroma, is malignant, and that would determine the term adenosarcoma. Or you could say not only is the stromal component malignant, but it looks like it might be more than one phase. It might look like cartilage, it might look like bone, it might look like fibrous tissue, it might look like blood vessels. If that's the case, it's called mixed mesodermal. So not only is it mesoderm derived, but it's mixed, it's multiphasic sarcoma. If the glandular cells look clear, you can use the adjective clear cell. And there's a couple of other ovarian, Mullerian derived tumors called Brenner cell tumors, which look almost identical to transitional cell carcinomas. But then there's also another thing called transitional. Now remember, these are germinal epithelium. These are not germ cells. And of course the germ cell ones are just like the males. They can look like a seminoma, only in the woman it's called a dysgerminoma. They can look like a teratoma. They can look like a yolk sac tumor. The same kind of thing we saw in the male. So here's a tumor, the wall of a cyst. It looks like it's columnar. And just out of curiosity, we opened this little cystic tumor. You could see a nice lining. Would you call this serous or would you call this mucinous? Well, I think you know what mucin looks like in a cell by now, and we're going to see it. Can I ask you another question too? If there was just basically a rather thin lining of epithelium on this big cyst, would you just call it a cystoma? Or let's say that these little glands were very prominent as well. It wasn't just a cyst, but there were also glands. Would you call that a cystadenoma? Yes. So these are the terms that are used, whether it's basically just a sort of a flat epithelial lining or whether there's a lot of secondary glandular growth. This area here would probably be called cystoma, and if there are a lot of these little secondary glands, you might call them. They look benign. They don't secrete mucin. And remember, there's 3 categories of these: benign, malignant, and thank God they let us introduce the 3rd category of borderline. So a lot of times pathologists will be looking at these and they'd say, well, gee, I'm not too sure if they're really benign or malignant. It kind of looks kind of borderline. Well, guess what? The borderline category is technically allowed. Okay? Now, if somebody has a borderline category of a cystic tumor like this, but she also happens to have ascites in the abdominal cavity, do you think you'd want to change your diagnosis to malignant rather than borderline? Yes. And by the way, somebody just used another very important word here. If you think that these little foldings look a little bit papillary, you can use the word papillary, especially if these little finger-like projections are prominent. Now let me ask you this. Do you think that this cyst, whether it's benign or malignant, is serous or mucinous? Take a look at the cells. That's all mucin in there, isn't it? If you did a Mucy-Carmen stain, that would be as red as hell. Now, do you think if this was the only thing, if it was just in the lining, would you call this a cystoma or a cystadenoma? Right. Now, let me ask you the key question here, because I know you're all little experts by now. Does it look benign or malignant? It's benign. What if it was, what if it worried you? It looked a little bit malignant, but you weren't sure. What would you call it? Benign, malignant, or borderline? Absolutely. Isn't that wonderful that they let us hedge? Okay, let me show you another one here. Let's say that we don't know if this is benign or malignant, but we do know 2 things about this. We do know whether it's serous or mucinous, right? Is this serous or mucinous? Okay, now the second question. Is there any other adjective you'd like to give to this tumor, cystic type tumor? Yeah, papillary. Look at all these little things are papilla here. That's beautiful. Here's some more papillary stuff, close up, and of course, papillary lined by serous cells. If they were mucinous, they wouldn't look pink, they would look white and washed out. And let me show you another thing. Here's another papillary tumor. And this one happens to be adenocarcinoma. But let's say that you agreed because you saw a lot of these cells were very dark, and maybe she's had an ascites as well. By the way, an ascites in an ascites in any woman that has malignant cells is ovary cancer until proven otherwise. Okay. Now, so not only is this malignant and not only is this serous, but let's say I could make a case that some of these little things are sort of papillary, even though it's not well demonstrated here. Here's probably part of a papilla. Now, can I ask you a question? Do you think that some of these little papillary structures here are kind of like drying up, perhaps? I don't know. It would be a hard question to ask you from this picture. But let's say some of these little papillary structures dried up. What would you then call them if they became dried up and calcified? You call them a Samoma body. So a Samoma body technically is any dried up papillary structure, usually from carcinomas, and is not specific to the ovary. Remember, we saw them in thyroid, you could see them in breast, you could see them in colon, but technically Psammoma bodies are the most common, probably in ovary. Remember, we also called a psammoma body in meningiomas as well. But remember, in the meningioma, there were no papillary epithelial structures. We just said those were just meningeal fibroblastic cells arranged like a whorl. Okay, folks, I got to ask you the world's easiest question again as a test. You could look at it and cheat it if you want to. I probably would. Which one is serous and which one is mucinous? What is this on the left over here? Right. What is this on the right? Second question is, do you think you would need a damn microscope to know whether this cystic ovarian tumor was serous or mucinous? All you'd have to do is cut it open with a regular knife. And if it looked like it was mucus, it's going to be mucinous. If it looked like it was clear water, see, there's mucin over here too. If it looked like it was clear water, it's probably going to be serous. Okay, that was just a little test. It wouldn't be fair. I don't want to turn this into a big... I don't want to be accused of bringing in too much pathology here. But I wanted to give you a few other quick names of other Mullerian-derived tumors, most of which are malignant, by the way. And I wanted to show you a quick picture of them. If the glands look very much characteristic like we see with endometrial carcinomas, you can also use the term endometrioid or endometroid. And like the other ones, serous or mucinous, they can be a benign, malignant, or borderline. And by the way, you see that? Now I know what you're thinking. You're thinking, well, this just looks like an adenocarcinoma. How can you really say this looked more like endometrial rather than ovarian? Well, that's a good question, but let's just say that if you looked at a zillion endometrial cancers, you would say, well, this one looks a lot like the endometrial. So you call it endometrioid. Okay. What would you call an adenocarcinoma of the ovary that had a lot of clear vacuoles in the cytoplasm, but it wasn't mucus? It's just an adjective. It's clear cell. Okay? Now remember, pathologists love to subclassify adenocarcinomas. And you can do studies and to say that clear cells have a little bit better survival than the endometrioids, or the Brenners never metastasize, so they're benign. They love to look at things under the microscope, find different patterns, and then do big studies and talk about prognosis. But I just want to tell you, these are basically all adjectives. Here's another tumor of the ovary. But in addition to the glands here, you have a lot of smooth muscle or fibrous tissue as well. So this is probably at least as much stroma or fibroma type tissue as there is glandular tissue. And not surprisingly, it's called cystadenophibroma. Okay? It wouldn't be fair if I didn't tell you there's something called a Brenner tumor. And if you were to look at this, and if you remember our discussion of lower urinary tract, we said that these look like cells that are transitional cell carcinoma. They're multi-layered, they're papillary. And if you told any world-famous pathologist this was from the bladder, he'd call it a transitional cell carcinoma without even blinking his eyelids. Of course, if you told him it was from the ovary, he'd say, oh, I knew it was a Brenner tumor. So these are the ones that look exactly like transitional. I got to show you something else as well. No, I have to go off a little bit. When I made some of my YouTube movies, I was a little confused. I made a verbal boo-boo. I said that Brenner tumors were derived from germ cells rather than germinal epithelium. And I probably got about 20 people that jumped all over me and said I was wrong. And of course I was, but I'm not going to admit it. I'll just call it a verbal typo. Here's another carcinoma, an adenocarcinoma. But look, in addition to this glandular component being obviously malignant, disorganized, big cells, all that, look at the stroma surrounding the glands. That's also malignant as hell. So whenever you have clearly malignant stromal as well as glandular components, you call it a carcinosarcoma. or adenosarcoma is the more preferred term. And in addition, if there is a malignant stromal component, but it has more than one appearance, maybe it looks like bone, maybe it looks like cartilage, maybe it's like blood vessels, maybe it looks like fibrous tissue, then that would deserve the name mixed Mullerian. Mixed meaning the connective tissue component. Okay, question is, what side of this picture is connective tissue and what side of this picture is glands? What's on the left side here? What is all of this less pinker stuff? Okay, now what about all this darker pinker sort of circular stuff here? Okay, good, you got a good feeling for it. And for those of you who have been here a long time, you're thinking that's probably an unnecessary question. For those of you that are pretty new, you're probably wondering what the hell I'm talking about. We're done with the single biggest category of ovarian tumors, which are, of course, Mullerian origin, also called germinal epithelium. And that's a very tough term because the next group of tumors is called germ cell, which is different from germinal. So all of those tumors that we talked about in the testicle, like teratomas, seminomas, endodermal sinus, choriocarcinoma, guess what? They occur in the female too. Now, the general big difference between male teratomas and female teratomas is that male teratomas are usually malignant, which means they look immature when you look at them microscopically. And the vast majority of all female teratomas are benign. In fact, in the older days, they were just called dermoid cysts because they had elements of skin and they were cystic. But now they are generally called teratomas grade 0. In other words, they're not malignant. And like in the testicle, the more tissue you see that's immature and it's not well developed into either thyroid or nerve or retina or tooth or bone or whatever, more likely it is to be malignant. The dysgerminomas in the female look very, very, very much like the seminomas in the male, with the undifferentiated cells and the lymphocytes. Remember that? And of course, the endodermal sinus tumor in the female looks exactly like the endodermal sinus tumor in the male. And in addition, the choriocarcinoma in the female looks exactly like the testicular choriocarcinoma. So look at, that's two places where we can get a choriocarcinoma, both the ovary and the testis. And we've ignored the most obvious place, and that's the placenta. But we'll be talking about that later. So the most common solid ovarian tumor of a young woman is a teratoma. And they're almost all benign. They're called dermoid cysts. They may have elements of smooth muscle, but the two things they almost always have are hair and sebaceous material. And that's why they're called dermoid, because these are elements of skin. But if you look hard enough, you might see a little bit of bone, a little bit of thyroid. And of course, if they have a lot of immature elements where you can't recognize them as being differentiated structures, then you're thinking maybe this isn't benign. But most of them are benign. Here's a nice picture. And if I was to show you this, you would think I was showing you normal skin with hair and sebaceous glands and sort of a, well, this is sort of a non-keratinized hair, but then there's junk up there. This is your classical wall of a dermoid cyst, the most common tumor of the ovary in a young woman. Here's another tumor, and you don't know what it is, but once again, if you took sections through these and you had a hard time recognizing well-differentiated hair or well-differentiated thyroid or well-differentiated nerve, it looked all kind of primitive, then you're going to probably say this is not the usual type of benign teratoma in a woman, but it may be malignant. Actually, these cells here are from the retina. My son would know that because he's an ophthalmologist. But parts of it don't look very much like retina at all. And in addition, even though some of this tissue you might want to call neural, or, by the further stretch of the imagination, in this area here you can see it almost looks like normal retina. But the more you see neural type tissue that doesn't really look very well developed, the more you would say it's more likely to be immature, and the more likely it is to be malignant, and the more likely it is to behave malignant if it doesn't mature into well-defined structures like this. Remember when we took a picture of the seminoma? It was kind of uniform. This one has a little bit of fibrous tissue, but look, this is a dysgerminoma of the female, and it looks like a lot like the seminoma in that it has a lot of these germ-looking cells, like the spermatocytes. I hate to use that term in a woman, but that's exactly what they look like. In addition, you can see a little peppering of lymphocytes here and there. You can also see some abnormal mitoses. So all dysgerminomas in the female are like all the dysgerminomas in the male. They're regarded as malignant. Remember when we looked at the so-called endodermal sinus tumor? We said that it has the so-called Schiller-Duval bodies. I wouldn't go into these too much, but if somebody does throw the word Schiller-Duval at you, you know it's a tumor of either the ovary or the testis, in which the body looks like a bunch of tumor cells surrounding a blood vessel. We have a picture of that in lab. And by the way, let's say this is exactly the same picture that we showed you in the testicular choriocarcinoma, which may have had a very large serum level of HCG, human chorionic gonadotropin. So this would be a good tumor marker for this tumor, wouldn't it? And choriocarcinomas, of course, they're all malignant, whether they're in the placenta, whether they're in the ovary, or whether they're in the testicle. And we're done with our germ cell tumors. Let's see where we are in terms of time, by the way. Could we finish this or not? No, I don't think we could finish it, but we can almost finish it. So let's go into the other categories of tumors. We've mentioned the Mullerian or germinal. We've mentioned the germ cell. So let's just go into the other minor categories. Let's talk about the sex cord stromal tumors. Just like we had stromal and sex cord tumors in the male, you can have now in the female. And these are predominantly tumors of either the granulosa cells or the thecal cells. And just as though we had Leydig cell tumors in the testicle, which could produce extra testosterone in the male, you can have Leydig cell tumors in the ovary, believe it or not, that also produce excess testosterone. And that's why they're called androblastomas. But most of the sex cord stromal tumors in the ovary are in the family of the granulosa or thecal. So very often they're called granulosa thecal or fibrothecal. And if they're called fibrothecal, they may look more like fibromas, and they're less likely to be secreting estrogen. But if there are granulosa or granulosa thecal, they may very likely be functional. In other words, result in hyperestrogenism. Here's a sex cord stromal, and to you, it may look like just a perfectly nice little fibrous nodule, like a fibroma. Well, it may be called a fibroma, but it also may be derived from thecal cells, and most likely theca externa, which looks like fibroblasts. And here's a cut surface of it. And even though it's theoretically from thecal cells, it's not likely to secrete estrogen. Okay. You know what? I think I forgot to mention an important thing. I skipped over a cell here. I think we should... I'm sorry I skipped this one first, because this was even more important. Now, these also look like granulosa or thecal cells. These are actually granulosa cells. And this is a granulosa cell tumor. Now, from your point of view, you would say, well, it looks like any other plump cell I've seen. But look at, some of these cells are arranged with a little central core of what looks like commonly shared cytoplasm. Almost glandular, okay? But for the most part, they just look like heaps of granulosa cells. These would be most likely or very likely estrogen positive if you did stains, or if you measured the woman's estrogen level, she could have very high estrogen level. She can also have estrogenizing effects, you know, hyperplasia of the breast, hyperplasia of the endometrium. But these little structures here, because you got to learn some of the terms quickly, are called Call-Exner bodies. So if you hear the term Call-Exner body, it means it's a granulosa cell tumor. Doesn't necessarily mean it's benign or malignant, but it's producing these little, what you might think of as a rosette in a neuroblastoma, might be called a Call-Exner body in a granulosa cell tumor. And yes, these are very, very likely to be functional, producing increased estrogen. And I'm sorry I gave you this one after I showed you the one that doesn't produce estrogen. So remember, the granulosa cells, theca interna, estrogen rich, but this E, theca externa, zero estrogen. Okay. Should we stop now? Yeah, I think we should, because we only have 2 minutes left. So that means in the next session, we'll probably be able to do the rest of these very quickly. And either we'll have a lab or maybe we'll get right into breast. I haven't decided yet, but it will depend on what I think about this. We're done for the day. I'm going to open up the question box here and see if anybody has a verbal question they'd like to ask. Even though most of you don't, remember, I would never want you to think you can't ask a question. And especially when Dr. Kumar gets here, I want you to ask him a lot of questions. Bug the hell out of him. Okay, here's the question box. Whoops, that's not it. The attendee list. If I see hands, you're going to speak. Otherwise, I know that you understand everything, so you don't have to ask questions. I'll pop this back out again. Now I'll look at the chat question box, and I see a lot of comments, and it looks like most of them are thank you, thank you, thank you. And of course, that's the thing that keeps me going. Somebody asked a question. How long does the normal corpus luteum of pregnancy last? Well, it just lasts during the pregnancy. And quite frankly, after pregnancy, it deteriorates. So, you know, to nourish that endometrium, the decidua, and even the placenta, and of course with lactation, you need a lot of progesterone. So I'll say it lasts the entire pregnancy. If you Google it and I'm wrong, then I'll change my opinion. Somebody says, greetings from Melbourne Beach. I love Melbourne Beach. We used to go there every single week to a great sushi place. Okay. Ovarian serous and mucinous is believed to from surface epithelium. Is it true? Yes, but it's also regarded as Mullerian derived. Okay, and it's also called German ull rather than germ cell. I was confused about this for many years until I got it right, and I hope you're not confused anymore either. Okay, well, thank you. And you know, when my dog is bad, I usually have to have a little talk with him, and usually he understands and he gets better. If he barks at somebody, you know, I have a little talk with Woofy, and it's well worth it. Now, I was also thinking, what about when the master is bad? What about when people are bad? Is there anybody that we should talk to so we could get better? Well, I've always wondered about that, so that's why I think Randy Travis here has the answer to that question. See you next week, folks.
I'm gonna have a little talk with Jesus when I get home tonight. I'm gonna tell him all about my troubles, and I know he'll make them right. Then I'll ask him to forgive me for the things that I've done wrong. I'm gonna have a little talk with Jesus tonight when I get home. This world can be a struggle, just living day to day, and you'll run into the devil with every step you take. I've seen his face 100 times as he tried to lead me wrong. But he don't understand that I don't walk this road alone. I'm gonna have a little talk with Jesus when I get home tonight. I'm gonna tell him all about my troubles, and I know he'll make them right. Then I'll ask him to forgive me for the things that I've done wrong. I'm gonna have a little talk with Jesus tonight when I get home. The Lord said I could call on him whenever I feel low. Any time or place I needed him, he would gladly go. And my life has not been perfect, no matter how I try. But he's never turned his back on me, and that's the reason why. I'm gonna have a little talk with Jesus when I get home tonight. I'm gonna tell him all about my troubles, and I know he'll make them right. Then I'll ask him to forgive me for the things that I've done wrong. I'm gonna have a little talk with Jesus tonight when I get home. I'm gonna have a little talk with Jesus when I get home tonight. I'm gonna tell him all about my troubles, and I know he'll make them right. Then I'll ask him to forgive me for the things that I've done wrong. I'm gonna have a little talk with Jesus tonight when I get home. I'm gonna have a little talk with Jesus tonight when I get home.
Rock on, you buzzards.